Welcome to this deep dive. It's fascinating how often health issues aren't just a simple one and done thing. They get tangled up with so many other parts of life, what's going on in our heads, our family dynamics, the environment we live in.
Absolutely. You see it constantly in practice. Patients aren't just a collection of symptoms. They're people living complex lives, especially, when you're dealing with multiple conditions or older adults.
And that complexity is exactly what we're exploring today. We've got some great source material here, a webinar and a toolkit designed to help family physicians navigate these tricky situations.
Right. Focusing on using clinical scores, particularly with elderly patients who have challenges like diabetes and mental health issues.
So our mission here is really to unpack the comprehensive approach these sources advocate for. It sounds like a holistic model for assessment.
It is. And we'll see how different clinical scores aren't just numbers, but tools that help paint a truly complete picture. We're going to anchor this whole discussion around a detailed case study, a patient and his son, actually, to make it real.
Okay, I'm ready. Because looking beyond just the surface symptoms using this kind of framework, it sounds like it can reveal connections that completely shift how you understand someone's health picture.
It really can. So the sources introduce this framework used in family medicine called the three-stage assessment. It's presented as a way to get a comprehensive view of a patient, beyond just their chief complaint.
Okay, so it's like dividing up the information you gather about a person into different buckets, sort of. What are those three stages?
Precisely. It helps ensure nothing crucial gets missed. First, you have the clinical or biomedical stage. This is probably the most familiar, the traditional medical stuff.
Right, symptoms, history, exam.
Exactly. Symptoms, past medical history, physical exam findings, diagnosing diseases, identifying risks like high cholesterol or smoking, and health promotion stuff. The biological engine, if you will.
Got it. The body and its mechanics. What's stage 2?
That's the individual, their personal psychological stage. This is where you focus on the person experiencing the health condition. What are their perceptions, beliefs, their feelings about their health? How are they coping? Are there psychological stressors? What are their motivations or, barriers when it comes to managing their health? It's their inner world.
So it's not just having diabetes, but how they feel about having it, maybe their anxiety about managing it, that kind of thing.
Exactly that. And the third stage is the contextual or social environmental level. This looks at everything outside the individual that impacts their health.
Like what?
Family structure and support, living situation, work or retirement, education, finances, community connections. Social determinants of health are huge here.
So their living situation or how much support they get from family could be just as important as, say, their blood pressure reading.
Often, yes. The sources really highlight that these three levels are interconnected. A problem in one area almost always affects the others.
Right.
And using this structured approach ensures you're seeing the whole person, which in turn helps create a management plan that's truly individualized and tackles the root causes and contributing factors, not just the symptoms. It shifts care to be genuinely person-centered.
That makes so much sense. You're building a much more complete picture. So
Okay.
how does this actually play out? The sources give us a case study, right?
They do. A detailed one. We're introduced to Mr. Suresh Kumar, a 68-year-old retired railway employee. When he first came in, his presentation was already quite complex.
What was he complaining of?
Forgetfulness, low mood, anxiety, poor diabetes control, pain from osteoarthritis in his knee, some bothersome urinary symptoms, and just, increasing difficulty with daily activities.
Wow, that's a lot for one person to juggle. What was his established medical history?
He had type 2 diabetes for 12 years, managed with oral medications. He also has hypertension and osteoarthritis. They did note he didn't have any prior fractures, which is relevant later.
Okay. And his son, Mr. Anil Kumar, was involved.
Yes, Mr. Anil Kumar is 42 and lives with his father. He was there, and he was actually quite concerned about his own diabetes risk, given the family history.
Okay. So that immediately flags a family component that this framework could help address.
Definitely.
All right, let's apply that three-stage assessment framework to Mr. Suresh Kumar's situation based on what the sources found. Starting with the clinical or biomedical level, what were the key findings beyond that list of complaints?
Okay, so clinically, his BMI was measured at 28, which puts him in the overweight category. His blood pressure was 138 over 84 milli-Hg, so borderline elevated. On examination, they found no signs of focal neurological deficits, which is important given the forgetfulness concern.
Okay. Moving to the individual psychological level, what was going on inside Mr. Kumar's head? What did they find there?
This is where we find some really significant pieces. He expressed a lot of anxiety, specifically about his memory getting worse and the potential complications of his diabetes. He also described feeling demotivated and embarrassed. The embarrassment was linked to his self-care routines, and particularly those urinary symptoms. And a big worry for him was becoming a burden, dependent on his family.
You can already see how those physical symptoms are weighing on him emotionally. Okay, and the contextual social level, what was his world like?
Well, he lives with his wife and his son, Mr. Anil Kumar, and his daughter-in-law. The family is described as supportive, but also busy.
Okay.
And crucially, his social activity had become very limited, especially since the pandemic. And he was actively avoiding outings, specifically because of the unpredictable and urgent need to use the bathroom, those urinary symptoms.
So that adds a really significant layer of isolation, and it reinforces that worry about dependence you mentioned.
Exactly. It connects directly back to his individual concerns.
This is where the clinical scores come in, right?
Yep.
To help quantify these different layers. Let's look at the scores the sources provided for Mr. Suresh Kumar.
Exactly. These scores give objective measures to some of those subjective complaints and observations. First, his GAD-7 score was 11.
GAD-7, that's the Generalized Anxiety Disorder Scale, isn't it?
That's right. A score of 11 indicates moderate anxiety. Then his PHQ-9 score was 15. PHQ-9 is the Patient Health Questionnaire used for screening depression.
And 15 tells us?
That signifies moderately severe depression. So these scores confirm and quantify the anxiety and low mood he expressed in that individual assessment stage.
Okay, makes sense. What about his forgetfulness? Was there a score for that?
Yes, they use the GPCOG, stands for the General Practitioner Assessment of Cognition. His score was 3 out of 9.
And what does 3 out of 9 on the GPCOG mean?
That score suggests that cognitive impairment is likely present, and it warrants further investigation. So it directly relates to his complaint of forgetfulness.
Okay.
Next, they looked at his diabetes self-management using the DSM-Q, the Diabetes Self-Management Questionnaire. His score was 10 out of 24.
And that ties into his reported poor diabetes control, I assume?
It absolutely does. A DSM-Q score of 10 out of 24 indicates poor diabetes self-management. It confirms that behavioral aspect contributing to his clinical picture and links back to his feelings of demotivation about self-care.
Got it. Now remember his urinary symptoms? The reason he avoids going out.
Yes, the contextual factor of isolation. Right. So they used the IPSS, the International Prostate Symptom Score. His score was 21.
And that quantifies the severity of those symptoms.
Precisely. An IPSS score of 21 is interpreted as severe lower urinary tract symptoms, or LUTS. This score gives objective weight to the symptom that is directly causing his social isolation. There's a really clear link between a clinical finding and a contextual problem.
That's fascinating how one number can help explain such a major social challenge he's facing. What about his bone health risk? Did they look at that?
They did. They calculated his FRX score for India. FRX estimates the 10-year probability of a major osteoporotic fracture and a hip fracture.
And the numbers were?
His scores were 4.4% for major fracture and 1.4% for hip fracture. Now, the interpretation given in the source is that while these scores are technically below the typical Indian treatment threshold, they're close enough that you should really consider a bone mineral density test, a DXA scan.
Good to see that risk wasn't overlooked with everything else going on. And finally, how do they quantify his difficulty with daily activities? You mentioned that earlier.
For that, they used the Barkle Index of Activities of Daily Living, or ADL. His score was 70 out of 100.
What does 70 out of 100 on the Barkle Index tell us?
It indicates moderate dependence. So this score objectively captures the functional impact of his various health issues, his knee pain, maybe his cognitive status, general deconditioning on his ability to manage daily life, and that ties right back into his worry about becoming dependent.
Right.
They also noted he has a high diabetes risk profile overall, just adding another layer to managing his existing condition effectively.
Okay, so looking at all these scores together, GAD-7 and PHQ-9 for mood, GPCO for cognition, DSM-Q for self-management, IPSS for urinary symptoms, Barthel for function, even FRAX for fracture risk, how do they help pull together that full picture from the three-stage assessment?
This is where it gets really interesting. The scores don't just sit in isolation. They reinforce and quantify the connections we've been talking about.
How so?
Well, his severe LUTS, that IPSS score of 21, that's a clinical finding. It directly leads to him avoiding social situations and feeling isolated, which is contextual.
Okay.
This isolation, combined with the physical burden of his symptoms, likely makes his moderate anxiety, GAD-7 score 11 individual, and moderately severe depression, PHQ-9 score 15 individual. Worse.
So the physical problem is feeding the mental and social problems. A vicious cycle, almost.
Exactly, and that low mood and anxiety, along with the functional difficulties quantified by the Barthel Index, 7-100 moderate dependence, make it incredibly difficult for him to feel motivated for self-care.
Which leads to the poor diabetes self-management shown by his DSM-Q score, 1024.
Precisely. Then you add his cognitive impairment, GP-SOJ 39. On top of that, it adds another layer of vulnerability, increases his dependence, reinforces his personal worries in individual, and also adds burden on that supportive but busy family. Contextual.
Wow. It's a complex web, isn't it? And the scores really help make those tangled threads visible.
Absolutely. It's far more than just he has diabetes and he's feeling down. It's showing why he might be feeling down and why his diabetes might be poorly controlled. It's linked to his urinary symptoms, his social life, his function.
And the sources even reinforce that depression is incredibly common in general practice, right?
Yeah.
And it isn't usually caused by just one thing. It's often tied up with other health issues like diabetes and social factors. That perfectly aligns with what we're seeing in Mr. Kumar's case.
It really highlights why a purely biomedical approach would miss so much of what's actually going on and why that comprehensive assessment is so essential.
Definitely. Now, you mentioned we should also briefly touch on Mr. Anil Kumar, the son. His concern about his own diabetes risk, that's something a comprehensive family physician should address, too.
Yes, absolutely. It's part of looking at the family context.
So how is his risk assessed?
They use the Indian Diabetes Risk Score, or IDRS. It's a simple score using basic criteria to estimate risk.
Okay.
For Mr. Anil Kumar, who is 42, that's 20 points just for age. His waist circumference was 96 centimeters, which adds 10 points.
Yeah.
He reported having a sedentary job with no regular exercise, which contributes a significant 30 points for physical activity level.
Right.
And because his father has diabetes, that family history adds another 10 points.
Okay, so his total IDRS score is 20 plus 10 plus 30 plus 10. That's 70.
Correct. His total IDRS score is 70.
What does a score of 70 indicate on the IDRS?
According to the source material, a score of 60 or more indicates a high risk for undiagnosed diabetes.
So he definitely needs some proactive attention. What were the recommended next steps for him, for Mr. Anil Kumar?
The sources recommended confirmatory blood tests, specifically fasting plasma glucose, FPG, and HbA1c to see if he actually has diabetes already.
Makes sense.
But regardless of that outcome, significant lifestyle changes are strongly advised, focusing on nutrition, increasing physical activity, and weight management. And ongoing monitoring is recommended, both for potential diabetes progression and other cardiovascular risk factors. It just shows how the assessment can naturally extend to the family unit when it's appropriate.
Okay, great. So bringing it back to Mr. Suresh Kumar, we have this incredibly detailed, multi-layered assessment quantified by all these scores, showing how interconnected his issues are. How does all this information translate into a practical management plan? What do you actually do with all this?
Right. This is where the power of that holistic assessment truly shines. The management plan outlined in the sources is tailored precisely to address all the specific problems identified across those clinical, individual, and contextual levels, and is directly informed by the scores.
Okay, walk us through that plan. What did it involve?
All right. For his diabetes, the focus is on dedicated education and self-management support, plus reviewing his current medications to make sure they're optimal, especially given his other issues. For his cognitive concerns, flagged by that GP-SOG score, a full cognitive workup is needed. And crucially, caregiver counseling for his family to help them understand and support him.
Right, addressing both the patient and the impact on the family again. Very important.
Exactly. For his severe LUTS, remember that high IPSS score, a urology referral, is necessary to investigate and manage the symptoms causing him so much distress and isolation. Medication or other evaluations will be considered there.
Okay.
For his moderate anxiety and moderately severe depression, shown by the GAD-7 and PHQ-9, a psychiatric referral is recommended. They can explore options like psychotherapy or medication, or both.
So bringing in the right specialists based on the quantified problems makes sense.
Yes. For bone health, given his FRAX score being borderline, a DXA scan is advised. Plus, reinforcing the basics like calcium and vitamin D, encouraging exercise that's safe for him, and really focusing on fall prevention strategies. Falls are a huge risk for fractures, especially with mobility or cognitive issues.
Definitely. What about his functional dependence, that Barthel score?
Right. Rehabilitation is key there, targeting that Barthel Index score of 70. This means occupational therapy to help improve his ability to perform activities of daily living, and physiotherapy to help with mobility and strength.
Okay, that covers the clinical and individual aspects mostly. What about the contextual factors? His social isolation and the family burden?
That's addressed through caregiver counseling. Again, supporting the family is vital. They'd also look at home safety modifications, maybe grab bars or better lighting, to reduce fall risk and potentially make daily tasks easier for him. And actively encouraging and trying to facilitate social engagement, perhaps suggesting activities that might be more manageable despite his urinary symptoms, really trying to combat that isolation piece.
And I imagine none of this is a one-time fix, right? It needs follow-up.
Absolutely not. Regular follow-up is built right into the plan. You need to monitor his progress across all these domains. His mood, his cognition, his diabetes control, those urinary symptoms, his functional abilities, and just his overall well-being. It's a continuous process, really, of adjusting the plan as needed based on how he's doing.
This management plan beautifully demonstrates how using that three-stage assessment framework and incorporating those specific clinical scores allows healthcare providers to create a truly comprehensive, individualized plan. It goes so far beyond just treating individual diseases one by one.
It really does. It addresses the whole person within their life context.
It's a powerful example of patient-centered care that sees and responds to the intricate connections between mind, body, and environment.
That's the goal, isn't it?
Well, we've definitely taken a deep dive today into this comprehensive approach to patient assessment in family medicine. We looked at the three-stage framework, the role of clinical scores, all made tangible through the case of Mr. Suresh Kumar and his son.
Yeah, and the key insight, I think, is really how interconnected our health is. It's rarely just one thing, is it? The most effective care seems to happen when you look beyond just the physical symptoms to truly understand the individual's psychological state and the world they live in.
Right. Those clinical scores aren't just data points. They are tools that help quantify pieces of that complex human puzzle.
Exactly. Thinking about Mr. Kumar, it's clear that tackling his urinary symptoms, for instance, might be just as critical for his depression and maybe even his diabetes management as adjusting his medications. It all links up.
Absolutely. So here's a thought to leave you, the listener, with. How might understanding the interconnectedness of medical, psychological, and social factors, like we saw in this case, influence the way you think about health and care? Whether it's for yourself or maybe someone you care about. What potential layers might be hidden beneath the surface of a health challenge, just waiting to be uncovered if we look at the whole picture?